Hi, good afternoon, and welcome to today's webinar. We're glad you could join us today. My name is Sarah Muller-Robbins, and I'm the Director of Education for the Partnership for Maternal and Child Health of Northern New Jersey, which is providing today's program. Our webinar today is titled Cardiac Assessment of the Newborn. I would like to review some information before we get started. Immediately after the webinar ends, as well as in a follow-up email, you will be invited to take a post-program evaluation. We appreciate your feedback, so please complete the survey. To receive a certificate of completion, including 1 nursing contact hour, you must listen to the entire webinar and complete the evaluation survey. Certificates of completion will be sent via email within 1 week of the webinar broadcast. This program is being recorded and will be available on the Partnership's website and YouTube channel. We will be muting all attendees' microphones during the presentation, but we welcome your questions and comments. Please use the question box and the speaker will respond to as many as possible at the conclusion of the presentation. Now I'd like to introduce today's speaker. Susan Ortega is a pediatric advanced practice nurse with a specialty in pediatric cardiology. She has 40 years nursing experience and currently coordinates the Pediatric Cardiology Cardiothoracic Surgery Program at St. Joseph's Children's Hospital in Paterson, New Jersey. Welcome, Susan, and thank you for joining us today.
Thank you, Sarah. I'd like to thank Sarah for the opportunity to speak to all of you, and I look forward to making this a little bit more comfortable for you. I know cardiac is always something people say they're not, they find challenging. I find the heart very organized. It has OCD like me, so kind of like that. First, I'd like to tell you that I have no disclosures, no financial disclosures, and as you can see from the slide, the endorsement by the partnership or any commercial products displayed is in conjunction with the continuing education activity. And Sarah already explained about getting your CEUs. So first I'd like to start, because I know a lot of you are perinatal people and NICU people, with the development of the heart. And so I have the diagram up first, but you should have the slide. You can refer back to that. The heart actually starts as 2 tubes which merge, and the single tube begins to swell. And then by the 3rd week of life, the heart is beating. The tube elongates and begins to coil to the right on top of itself, which is called dextral or de-looping, by the 28th day. Once the looping is complete, we then have blood flow through the heart, and the heartbeat, as I said, is at week 3. Now, normally we can't hear that, but we do have a heartbeat. But if you did like a transvaginal ultrasound, you would see a heartbeat. This is where the malrotations can occur during this looping process. If the looping occurs to the left, leval, that would cause the right ventricle to be on the left and the left ventricle on the right, which would be like transposition of the great arteries or dextrocardia. Once you have the looping, you have like a rudimentary common atrium and a common ventricle. And once you have blood flow through this tube, septation can occur, which is the division of the tube into, atria and ventricle, upper and lower chambers. At the end of the 4th week, we have a single great primitive vessel, which is called the truncus. And in week 5 through like 6 or 7, you will see the beginning of the cardiac septation, which is the atria first, and the way that the walls grow, they grow down from the top. The septum primum grows down from the top, and then the secundum septum grows parallel, like it actually has like almost like 2 walls, and that allows for the foramen ovale to develop. There's a little opening in there, which is necessary during fetal circulation, which we will talk about. And the heart layers are formed out of the mesoderm, which is like all your vascular systems and your kidneys and muscle, skeletal, all of that forms from the mesoderm, but that's where the heart and vessels form. The first fetal shunt is the foramen ovale, which is forming as these two septa form together and leave that space for the foramen ovale to happen. The other two components are the Peyton ductus and, of course, the ductus venosus, which is where the blood flow comes through the placenta. The ventricular septum follows shortly thereafter and also forms in that same way, where it grows up from the bottom and down from the top. The part that forms the apex is considered the muscular septum, and this is where sometimes you have failure of the septum to form completely, and you can have small ventricular septal defects. Sometimes these will even close during fetal life and repair themselves. The membranous portion is what comes down from the tricuspid valve and the endothelial tissue. Because the walls, if you think about the job of the walls of the heart, part of what they do is support the valvular structures. Not only do they septate and form the atria and the ventricle, but they also support your mitral and tricuspid valves and your aortic and pulmonary valves. So if you have failure in the septum to form, it will affect the valve. For instance, in the atrium, if you have a septal primum defect, which is an opening between the atria that's very close to where the endocardial cushion forms, you have an atrial septal defect, and that will affect the mitral valve, usually associated with a cleft mitral valve or mitral, a leak in the mitral valve. Once we have the septation, the valvular development, the wall development is complete, and the heart forms now two identified sides, a left and a right. Then you have a formation of the AV valves. Now this starts with this formation in the septum primum and the membranous septal formation, because as I said, they support these structures. Once the valves develop, you have a now upper and lower chambers of the heart. So that divides the heart again. And now we have four identified chambers: right atrium, left atrium, right ventricle, left ventricle, and then the tricuspid and mitral valves. The appearance of the AV valves complete that part of the anatomy. But at this point, we still have one great vessel, which is called the truncus, okay? So the truncus also needs to septate and rotate in order to form the aorta and pulmonary artery. And that Ductus Arteriosus, that single trunk, remains until week 7. There are little ridges that appear within that vessel, which eventually should fuse, essentially dividing this trunk into the two great arteries. And then they rotate to form the correct placement of the aorta coming off the left ventricle and the pulmonary artery coming off the right ventricle. In the normal heart, the aorta is posterior and the pulmonary artery is, I don't know if you can say it like that, but is anterior. Okay, so by the 8th week or 44 days into the pregnancy, the heart is complete. It mimics the postnatal circulation in terms of all the pieces of the heart, okay, are there. So if a defect is going to occur, it's already happened. Failure of the septum to close, or abnormality in the ventricle, in the ventricle or the atria, or a problem with one of the valves, or the trunk itself, like Ductus Arteriosus. If that doesn't septate, you would have a single vessel, single great vessel. So let's talk about the fetal circulation in general. I just have a simple diagram here. So as we know, the mother's job is to circulate and oxygenate herself first, and then the fetus. So the blood comes through the placenta, through the umbilical cord, into the hepatic system up to the ductus venosus, okay? The ductus venosus is what brings the blood into like the inferior vena cava into the right atrium. And then some blood supply comes from the superior vena cava, which is the head, neck, and shoulders, as that drains also back into the right atrium from the baby's circulation. So we have the blood coming into the right atrium. The right atrial pressure in fetal life is a little bit higher, and it needs to be because it needs for that foramen ovale to work. And in order for that to work and the blood to go across it, it has to have a slightly higher pressure than the left atrium. And remember that during fetal circulation, we have what I always say is passive circulation, right? Mom is providing, is doing all the work for the fetal heart. We don't have systemic and venous circulation during fetal life because the lungs are not working and the blood is just coming in. Your ventricles are basically the same pressures. They're not, you don't have a systemic and venous circulation then. It's not, both pressures in those ventricles are the same. All right, so the blood comes into the right atrium. Some blood will go into the right ventricle. Much of it goes across the foramen ovale into the left atrium. The blood that goes into the right ventricle will then go to the pulmonary artery. And here's where it encounters the Peyton ductus arteriosus, which is that connection between the aorta and the pulmonary artery. In fetal circulation, the blood goes from the right side, right, the pulmonary artery, over to the aorta, all right? And that's what we want. Only about 8% of the circulation actually goes to the lung. Why? Because the lungs are not functioning. They're fluid filled at this point, not air filled, okay? And the pressure inside the lung is high, so it keeps the blood out because mom is oxygenating the baby. The blood goes out the aorta to the system, some of it is in the left atrium as it came across the foramen ovale, so it goes into the left ventricle, and that part also goes out to the aorta. Goes back to the baby's body, and then goes in the umbilical artery back to the placenta to get, more oxygen and nutrition, okay? So let's talk next about the transition to neonatal life, postnatal circulation. Once the onset of breathing occurs, and the placenta is tied off, the placenta, the ductus venosus, the flow from the ductus venosus, which is from the placenta, immediately decreases. However, the ductus venosus stays around for like 3 to 7 days. So for babies that are preemies or sick newborns, that's how we do when we put an umbilical artery line in. We can go into the umbilical artery or to the ductus venosus. That stays open. Eventually, it fills up both of them with fibrin and close off completely. But once the baby is breathing on its own, you get a decrease in the pulmonary vascular resistance, or that pressure in the lung. It drops part of the way, but it does not drop to normal, okay? You may still have some flow across the foramen ovale, okay? But it goes from being right to left, or it should go from being right to left in utero to left to right postnatally. And that is important because if you have a newborn with persistent pulmonary hypertension, right, or some other illness that is causing the lungs to not work properly, you will see that flow continuing right to left. And that's something that we would watch very carefully, okay? The PDA may still be open. I always tell parents when we do an ultrasound on a new baby and we see that the foramen ovale and the Peyton ductus are both open on day 1 or day 2 of life, this is really not shocking to anyone. Our only concern is if the flow is right to left rather than left to right, okay? The pulmonary vasculature will constrict more if the baby is hypoxemic, if there's hypercapnia, or if the baby is acidotic. The wall thickness, as I said earlier, or the pressures in the chambers, left and right ventricle, are the same, right? Because we had a passive circulation. And it takes a bit of time for that left ventricle, as it begins its own workload, to become the systemic or higher pressured ventricle. And the right side does not need to be a high pressure system because it's pumping the blood only to the lungs. We have a high percentage of fetal hemoglobin, right? Because during fetal life, the mother oxygenates herself first and then the baby. So there's more hemoglobin to carry more oxygen. And now that the baby, a term infant, is fully oxygenated, they need to start breaking that down, which if they don't do a good job of that, we have jaundice. The functional closure of the Peyton foramen ovale, we say that that is usually by 3 months of age, but that is not a hard and fast rule. Some close early, in a few days. Many times we see it open past 3 months, but it does eventually close. And an important thing to note is that in about 1 out of 5 people, the Peyton foramen ovale never closes. It's not considered a heart defect. We could not tell you which, if you gave me 5 babies, which baby's PFO is going to remain open. But in children, we don't do anything about it. In adults, we know that there are a very small percentage of people who have a Peyton foramen ovale that can have a stroke, and they sometimes feel that the stroke is related to reverse flow in the foramen ovale. In other words, right to left. If they have an embolus or something, it can go across into the left atrium and up to the, up to the brain. And there's some studies that also show that people that have a foramen ovale and high incidence of migraines, for instance, at least 2 migraines a week, if they have a Peyton foramen ovale, there is research that shows that those patients benefit from having that PFO closed with a device, and it reduces the number of migraines. It also reduces the risk of a subsequent stroke. The PDA in a full-term baby that's healthy usually will close 24 to 48 hours, but we say 4 to 10 days. My theory is that if you need the ductus to remain open because you have a ductal dependent cardiac lesion, the ductus will close on the first day of life. And we know that the use of prostaglandins will keep the ductus open. One thing I want to mention about the ductus is that in premature babies, the lower the birth weight, the higher percentage they have of the ductus remaining open. So lower weight, and the more premature they are, the more likely they are to have a patent ductus that remains open. And in preemies, we see that a patent ductus can cause apnea. And so one of the things we look at if we're having difficulty weaning a preemie from respiratory support is a cardiac evaluation, because we want to see, do they have a ductus? Okay. The next thing I like to what I always tell my nurses, it's like the same for like an EKG, right? If you know what the normal stuff is, then if you know what normal is, then abnormal reveals itself. So I always like to go over what the normal, excuse me, the normal pressures and saturations are in a normal heart. So we know that the atria, although they are pumps, they are not the main pumps. They are really receiving chambers. The right atria receives the deoxygenated blood, goes through the tricuspid valve into the right ventricle, the way that I always tell my nursing students how to remember which valve is on which side. The abbreviation for right is RT, tricuspid starts with T, and so you remember that the tricuspid valve is on the right side of the heart. For the purposes of this diagram, it shows the pulmonary artery coming out of the bottom of the heart, which we know it does not. It actually lays over the top. So the right atria, being a low pressure system, has a measurement of about 4 millimeters of mercury, right? Because it's not doing the main part of the pumping. Goes into the right ventricle, and you'll see that the right ventricular pressure normally is around 20 or 25, and it says over 0. When we measure our systemic blood pressure, we have systolic and diastolic number, but inside the heart, we want that number to be like 0 to 5, 0 to 10 max. And that's because that tells us the resistance to filling. So if you had a high number on the bottom, it would mean that the heart is not allowing blood to come into the chamber. So the right side, having only to pump to the lungs, which are right behind the heart, does not need a lot of pressure to generate the blood from its chamber to the pulmonary artery. If you measure the pressure in the right ventricle and you go into the pulmonary artery, those pressures should be the same, but you'll see that the diastolic number is slightly higher in the artery, which is normal. All right, there should be no difference in pressure from the right ventricle to the pulmonary artery, and that's because there should not be any obstruction to flow. So if you had a baby that had critical pulmonary stenosis, what you might see is a right ventricular pressure of 100, or as much, I've seen it as high as 200, and then you measure the pulmonary artery and it's like a normal pressure. So you can have 50, 75, or 100 millimeters of gradient. So how I always explain it to the parents, if you should have no difference between the right ventricle and the pulmonary artery, 0 gradient is normal, and then I tell you I have 100 gradient, then you know you have critical pulmonary stenosis. 25 difference, like pressures in the RV is say 50, and in the pulmonary artery is 25, you have a 25 millimeter, that's mild pulmonary stenosis. 50 is considered moderate, like 50 to 70, and then above 70 is severe, 100 is critical pulmonary stenosis. So the blood goes to the lungs, gets oxygenated, is brought back to the left atrium, the left-sided receiving chamber, through the pulmonary veins, which are the only veins that carry 100% oxygenated blood. That's always the trick question for anatomy and physiology, is which veins carry the oxygenated blood. There's 4 of them, and all 4 should be returning the blood to the left atrium. At this point, the left atrial pressure is just a smidge higher than the right side, because now it's a systemic receiving chamber. So that pressure is running around 6. The blood goes through from the left atrium through the mitral valve into the left ventricle. And the left ventricular pressure is usually what your systolic pressure is. So for a kid, you know, or an average person, 100, 120, but a baby, it's going to be a lot lower. And then again, the lower number should be like 0 to 10. And then the difference again between the left ventricle and the aorta should be 0. It should be the same, except in the aorta now you're going to see the same pressure as you would for your blood pressure, right? 100 over 70, 120 over 70, or if the baby's blood pressure is, 70 over 50, it should be that. The right side of the heart is deoxygenated blood. When I was young, I always thought that there was no oxygen left on the right side, but that's absolutely not true. So the average is about 75% of a desaturation. And the left side of the heart should be fully saturated, anything 95% or better. If all parts being equal, all the heart parts are there that are supposed to be, and the lungs are working properly, this is what you should see basically in a normal physiologic heart, a normal physiology in the heart. So what I wanted to talk about, because I think this is a big piece of what we do with newborns and preemies and children in general, is screening for what we call CCHD, critical congenital heart disease. And our physician here, Dr. Fuad Kablawi, was instrumental in having this implemented. St. Joseph's was one of the first hospitals in New Jersey that mandated the screening. And we did a lot of work on that, a lot of research, and to show that this is beneficial. So the screening tool, and that will come up in the subsequent slide, should be done on all newborns 24 to 48 hours of age or shortly, before discharge. If there's any concern raised during the newborn assessment, cyanosis, you hear a murmur, poor feeding, tachypnea, or some type of respiratory distress, you would consider doing the screening tool sooner rather than later. If you know that the mother has had a fetal echocardiogram and there's been some sort of positive finding, you might want to do your screening earlier to see if there's any, depending on what the diagnosis was, or if you have some other concern. What are some reasons that we do a fetal echo? Infant of a diabetic mother, whether it's gestational diabetes or if it's, a mother that has type 1 or type 2 diabetes. I always take, I find this entertaining because I was this mother, advanced maternal age, or now they call them geriatric mothers. I find that a little crazy, but if they're, over a certain age, they send them for screening. If there's a family history of congenital heart disease, whether it be on the mother or father's side, or the mother has some other things like lupus or other chronic diseases, multiple gestation like that are reasons that we might perform a fetal echo, or any abnormal routine fetal ultrasound, like if they don't think they see 4 chambers clearly or there's some echogenic focus, they would refer the patient for fetal. If somebody does not have prenatal care and has a risk factor, such as advanced maternal age or diabetes, or there's a family history, then I would consider, screening that baby sooner. And I always tell people, trust your clinical judgment. You know best. You're looking at the baby. Does something seem not right? Some of the most serious heart diseases do not have a murmur, so don't wait for the murmur, or don't say to yourself, oh, I'm just being neurotic. If something seems not right, go ahead and screen the baby. No one's going to fault you if you pick something up, right? And even if you don't, it's okay. So this is the algorithm, right? All babies at 24 to 48 hours. You should perform and document pulse oximetry in the right hand and either foot. Why the right side? If you had coarctation or ductal dependent lesion, right, the left side is going to be different. And even when we check pulses, I always teach my students and the residents, check both arms, right, and then the right and any lower extremity. All right, so if the pulse oximeter reading is less than 90% in either hand or the foot, if they fail, don't rescreen. It says, notify a medical practitioner, need for further evaluation, look for other causes, low oxygen, like persistent pulmonary hypertension, pneumonia, infection, some sepsis, some other congenital defect, or, sometimes full-term babies have respiratory distress for whatever reason. If the saturation is less than 90 in either the hand or the foot, it says the baby should have an immediate clinical assessment and referral to pediatric cardiology. In this case, don't wait and rescreen. If the hand and foot are, above 90% and they're 95 to 100, then the difference between the two measurements is 3 or less. If it's yes, if it's not 3 or less, they pass. A pass does not exclude the existence of a cardiac disorder. Again, if they fail, you're going to, if it's 95 to 100%, you're going to rescreen in an hour by obtaining new measurements in both the right hand and either foot. And after a total of 3 screenings, the baby does not pass, notify the medical practitioner and follow again as it states in the algorithm. Or if there's a difference between the upper and lower of 3%, then again, follow the protocol, repeat it. And then if they fail again, notify a practitioner. So one thing that I want to say, and this comes up a lot just with monitoring in general, the monitor is not the be-all, end-all. Like, we've had issues, and I'm sure other facilities have as well, where the monitors do this thing where it can double the heart rate. Like, we had an incident with one of our post-op cardiacs one day, and the primary nurse was at the restroom. Someone else was watching the child and said, "Oh my God, the kid's heart rate is over 200." And actually, it was one of my very new nurses who said, "Well, I'll listen to the kid while somebody else prints, a strip off the monitor." And I really gave her a lot of credit, because always look at the patient first, right? Our tools are not always perfect. You want to look at the baby. You want to examine the baby. Is there a reason to think something is wrong? So I'm saying, remember the exam. If you have an asymptomatic newborn with a murmur, suppose the baby's feeding fine, the baby's not tachypnic, the baby's not cyanotic, do an exam, do a cardiac exam and see what's going on with that murmur. So a detailed cardiac or cardiac focused physical exam would be, how does the baby look in general? Is the baby dysmorphic? When you look at the chest, is the chest symmetrical? Does it look like the heart's beating out of the chest, like very, visible apical impulse, or what we call a hyperdynamic precordium, right? The precordium is this area. Put your hand on it. Does it feel like a thrill or something like that? A thrill, to me, you use the palm of your hand, this area, place it on the chest. It feels like a babbling brook. If you had to put a visual with that, it feels like a babbling brook. And that's usually indicative of like louder type of murmurs. If you have a thrill, you usually have a grade 4 or more murmur. So we grade murmurs 1 through 6. So if you have a thrill, you have at least a grade 4 murmur. Feel the chest, feel the peripheral and central pulses, right? So it's not always easy to get pedal pulses in a baby. Like, feet are small. In adults, we do it all the time and we don't think about it. But feel the groin area. I always go to that area where the leg connects with the torso. You can feel those femoral pulses quite easily, or in the axilla, and see if you're getting equal pulses up and down, right? When you're listening, you're going to listen. I always tell people, listen over the entire precordium. Don't presume that the heart is on the left side where it belongs, right? Usually it sits center chest like this, with the apex towards the left nipple, right, 4th or 5th intercostal space. But you want to listen here at this is called the base, on either side of the sternum. This is where you hear pulmonary and aortic murmurs. If you have a ductus arteriosus, it's a continuous murmur. I tell people, if you hear that it sounds like someone swallowed a washing machine, that's a ductus. You can't hear anything else except that, like that. You can't hear S1 or S2. But you're going to listen both sides, first on the left, all the way down the sternal border, over to the apex. In newborns, always listen, well, in all kids, listen at the axilla and listen at the back. Can you hear the murmur at the back of the heart, through the lungs, if it's that loud? And then listen again on the right. The heart sound should be loudest on the left. So if you hear them loudest on the right, that's a reason to be concerned. You would get a chest x-ray to see if you had dextrocardia. Is the rhythm regular? Does it sound normal? Does it sound like there's skip beats or pauses? Does the murmur radiate over across the heart? And as we said, presence of thrills or clicks or heart sounds or any type of abnormal rhythm. We also want to look, does the baby have respiratory distress? Are they tachypnic? Are they grunting? Is there nasal flaring? Are they nodding their head? Babies in heart failure nod their head. I don't know. I always think of those dogs in the back of the car, those plastic things. Is there poor perfusion, right? What's the cap refill like? Are the pulses weak or normal? Is the belly distended? Is there hepatomegaly? Do you hear a bruit? Do you see cyanosis? What do those saturations looks like? And then what are the 4 extremity blood pressures, right? If the blood pressures are higher in the lower extremities, it's okay. But if they're lower, that's a concern. If there's a discrepancy between the upper extremity blood pressure and the lower, we now have to consider coarctation. Should always do 4 extremity blood pressures. And I know it's not easy to get in newborns, but it's essential. You'd be surprised how many kids have come into our office and never had their blood pressure taken. Today, excitement, we had a 9-year-old diagnosed with coarctation. First time was referred for hypertension, but actually had coarctation. So, so is the murmur pathologic? Anything greater than like 3 or 4, right? A systolic murmur greater than 3. Any diastolic murmur is not normal. So if you hear a diastolic murmur, so diastolic murmurs are graded 1 to 4. Regular murmurs are graded, systolic murmurs are graded 1 to 6. To me, a diastolic murmur, I always, when I teach people like how to hear it, because like they're common in kids who have tetralogy repair, because they have pulmonary insufficiency. It sounds like if you're in the mountains and you yell out your name and it kind of echoes back to you. A diastolic murmur is like that. You hear it and then you hear it again. And you usually hear it up in this area at the base. Does the baby, I'm sorry, I have a misspelling here, congestive heart failure, signs of congestive heart failure, right? Poor feeding, tachypnea, they can have pallor, reduced flow in the extremities, reduced cap refill. If they don't have any of that, then you would just watch physical, you know, recheck your exam, check your your pulse ox, and see how that progresses. If the murmur persists or the exam is abnormal, then you're going to do refer them to the medical provider, right? A chest x-ray gives us a lot of valuable information. It's not a hard or expensive test. It will show increased or decreased pulmonary vascular markings. That's the flow to the lung. So if there's too little or too much flow to the lung, that shows on the x-ray. If the heart is large, or if you have some sort of abnormal cardiac silhouette, like in tetralogy, they have like a boot-shaped heart. It literally looks like a big sock. EKG also gives us a wealth of information with, again, an inexpensive, easy test to do. They come right into the unit, to the nursery or to the intermediate nursery and perform that. It tells us if there's an abnormal rhythm, first of all, if there's any type of chamber enlargement, thickening of the heart, any type of heart block, like moms that have lupus tend to have babies that have congenital heart block. One of the things we know, like we teach our residents, is an axis, right? If you have a left or superior axis, which is the measurement on like how the rhythm, what's the word I'm looking for? Like they graph the EKG, right? Like on a thing. And so if the atrial axis is superior, that is very indicative, or almost always indicative, of some type of AV canal defect. If you have a right axis deviation, which is relatively common, and you can have that and still have a normal heart, but that would be an indication to rule out like an atrial septal defect. If you have left ventricular hypertrophy or right ventricular hypertrophy, we're looking for obstruction, right? Why is the chamber working so hard? Because there's something obstructing the flow. But any of these abnormalities, if you have a murmur in a newborn, an abnormal chest x-ray or EKG, we should be consulting a cardiologist. Or sometimes they won't even order the EKG until they think they're going to call the cardiologist, because that's one of the first things we want. I know everyone really wants an echo, but for us, the EKG is invaluable, and we want to see that as well as determining the need for an echo, okay? If the echo is abnormal, then the management, of course, would be based on whatever the diagnosis is. Is it a surgical case, or is it like maybe the baby has what's called peripheral pulmonic stenosis, a little bit of narrowing in the pulmonary arteries, which is kind of benign in the newborns. As the baby grows, the pulmonary artery branches grow width, and that like resolves in a few months. We do follow them until it does, but that would be an example of something not requiring immediate intervention, or a small VSD or an atrial septal defect, same thing. If the echo is normal, of course, discharge to home, and then if, depending on the diagnosis, based on echo, if it's complex, you might transfer the baby to a tertiary care center, or they still might go home, but making sure that they have cardiology follow-up after discharge. Just want to make sure I'm doing okay on time. So some considerations about the testing. I've been reading a lot of articles, and we've had a lot of discussions about this. So research in the United States shows there's a significant reduction in mortality rates by using the screening tool, right? States that had mandatory screening had a 33% reduction in early cardiac death from critical congenital heart disease than states that did not. CHOP did do a study. It was a single center study, just their facility, and they showed a decrease in mortality from 2009 and 10 to 2015 to 2016. However, they didn't credit the screening tool at all, but rather prenatal diagnosis of critical congenital heart disease rather than the mandated screening. The study size was limited, and it was only at their center. And what I say is that not everybody is CHOP, right? Not every person has access to advanced fetal medicine. Many places in the United States do, but if you look at, like, say, Appalachia, they do not. So always take that into consideration. Some parents, despite the availability of prenatal care, if they're uninsured, or they may not have had any of these studies. So this screening tool is extremely valuable. I wanted to talk a little bit about the home setting, because I know we have some visiting nurses that go out. I know they are invaluable to me in following my complex cardiac kids at home. And I looked at a study that was done in the Netherlands. I was a little surprised. They have a very high rate of home birth in the Netherlands. They also do very early discharge. Like if they have an uncomplicated vaginal delivery, that mom and baby will go home in 5 hours. So they looked at their screening for critical congenital heart disease in the setting where home births and early discharge occurred. They have a high percentage of prenatal screening where congenital heart disease is identified. So they do have a lot of fetal echo and fetal, diagnoses. But this study was designed that all babies born over 30, or equal to or over 35 weeks and were healthy and did not have a prenatal diagnosis of congenital heart disease. Those babies, if they had a prenatal diagnosis of congenital heart disease, those babies were not included in the screening. What they did with the screening was they timed it to the midwives or visiting nurse visits, because those, like, if the baby is delivered at home, the nurse might not come back for 2 or 3 days. Sorry, one of our unsatisfied customers screaming for an echo again. So rather than waiting 24 to 48 hours, the screening was done about an hour after birth, and then again on day 2 to 3 of life, okay? Those nurses, the midwives and nurses, of course, were trained how to use the pulse oximetry and how to do the screening tool prior to implementing this study. A positive test was considered after 2 abnormal screenings, like rather than if you saw in our algorithm that we check it again a 3rd time. They don't, because the nurse is not necessarily, or the midwife, going back yet again for a 3rd time. So if they have 2 abnormal screenings, they refer the baby. The first test is positive if the pre and post ductal sat was less than 90%. All right, 2 independent measurements within an hour would be done. A SAT less than 95 for both limbs, or a difference of 3% between pre and post ductal readings, was also considered positive. If the first screening was normal, then a second screening would be done on day 2 or 3 of life. All right. If that first test was positive, they didn't wait the 2 or 3 days to refer the baby. I just want to clarify that. If the second test was positive, a SAT of less than 95% in both limbs, or a 3% difference between limbs, then the patient was referred. So what they found from the study was that they had a high percentage of prenatal diagnosis in the region where the study was done, which they did not realize at the time when they conducted this study, but 73% of patients are screened. They included over 23,000 infants in the study. 20,000, more than 20,000 had the first screening. Almost 15,000 had the second screening, and 11,600 plus had both. 42% of those were home births, which is a high percentage. 5 of 10 infants that were identified were diagnosed with congenital heart disease. There were 5 that were missed and presented in heart failure, ranging anywhere from 7 to 49 days. 2 of the 7 late diagnoses died, and 2 had no screening. And it's not clear. The parents did have the option to opt out and not have the screening, so that could be a reason, but it wasn't indicated in the study why there was some with no screening. They had echoes performed on about 20% of the patients that showed positive. 25 showed some form of abnormality. 5 were considered critical congenital heart disease, which is something requiring immediate intervention. And 17 had non-cardiac things such as primary pulmonary hypertension. There was no control group that was not screened, so there wasn't an equal amount to compare that to. So from the home standpoint, what we want to take away is, although this group had an area, again, where there was a high percentage of prenatal diagnosis of critical congenital heart disease, there's still many areas, even in the Netherlands, that don't have that type of access to care. Of the positive tests in the first hours, 194, there was 194 positive tests. 4 had critical congenital heart disease. 190 did not, but of those, 123 had other significant pathology like respiratory, sepsis, or other type of congenital heart disease, and 10 had other medical issues. Of the positive tests on day 2 to 3, 32 were positive. 1 had critical congenital heart disease. There were 31 false positives, but 11 again had significant pathology. 7 respiratory, 2 septic, 2 other. So the research looks at, a lot of things about the algorithm and the testing in general to reduce the number of false positives, right? When do we screen? Like, do we do 24 to 48 hours? Do we do it sooner? Do we wait longer? However, lesions where the ductus closes, the infants can become critical, and newborns who develop sepsis or pulmonary hypertension also present themselves in the first 24 hours. False positive doesn't mean that the tool is not useful. Changes in screening, such as accepting the SAT of 95% with 1 repeat, have also been discussed. Screening and isolation cannot be our only tool. Evaluation of the newborn heart rate and rhythm should also be used. As we discussed earlier, the clinical exam. And I want to point out that coarctation is still one of the hardest diagnoses to detect prenatally, and also postnatally can be missed by pulse oximetry as well. Oh, I did exactly what you told me not to. Okay.
Okay.
I'm finished. If there's any questions, I'm happy to take those.
Sounds great. Well, thank you, Susan. That was a lot of information. You're really taking me back to nursing school and working in NICU years ago. It's a great review. We do have a few questions I'd love to start with. One
Okay.
is, how is Down syndrome related to newborn cardiac issues?
So any baby that's diagnosed with Down syndrome, well, there's a lot of early prenatal testing. Fetal echo would be recommended if we had suspicion of Down syndrome, early in the pregnancy. A fetal echo is generally done around 20 to 21 weeks, right? We said the heart is formed by, 44 days. So that's around the time that the heart is not only formed, but big enough for us to look at. So we like to examine them prenatally, but some parents, even if there's suspicion of Down syndrome, don't want further testing, don't want to terminate. We always screen a baby with Down syndrome for congenital heart disease in the newborn period. The most common defect that's associated with Down syndrome is a complete AV canal, which is ASD, VSD, and abnormal mitral and tricuspid valves. I will point out that 50% of kids with Down syndrome don't have heart defects.
Okay, good to know. Let's see, we have a question about the fetal heart is developed before often the mother even knows she's pregnant, so the heart must be most at risk of exposure of substances by the mother. Do you know if there are any specific chemicals or substances that can affect the heart?
So we know that alcohol, right, can cause fetal alcohol syndromes, which the most common defect with that is ventricular septal defect, but it's a host of other things for fetal alcohol syndrome. We don't know the exact connection between like illicit drugs, but it puts them at higher risk. We know that if a mother is exposed to like rubella or something in the early part of the pregnancy, many of those things can cause heart defects. And I'm trying to think if I also the thing with the cats, oh my God.
The litter?
Right, like taking care of cats, and at the, oh my God, what is that called? I can't think of it. My brain is just, but that also we know can cause congenital heart defects and diabetes. And I'm not sure what the exact link is with diabetes and congenital heart disease. We just know there's a higher incidence of a mother that is diabetic to having a baby with congenital heart disease.
Okay.
Virus, that's what I was thinking. Sorry. Oh my God. Senior.
No, that's great. Thank you for that. Another question is, why do babies with heart failure nod their heads? You mentioned the head nodding.
We don't know exactly. It's probably like in an effort to get more oxygen. Don't forget, they're like all kind of squished up, but they just do, if you watch them, they also sometimes grunt, but if you watch a baby that's in congestive heart failure, we do notice that they just nod their head ever so slightly. So
yeah,
I guess a physiologic thing as in terms of, they also like vomit a lot, like heart failure babies vomit a lot. I try on my kids, we're watching closely, like say a large VSD. We're always hoping it'll start to close or what we call become restrictive, where the heart demonstrates that it's trying to close itself, to position the babies, like pull them up, put like a burp pad, like, or a small diaper, roll between the shoulder blades, pulling the diaphragm up off the belly, because there's not, babies are squished, they don't have posture. And so if you have an enlarged heart and you have hepatosplenomegaly, that's pushing in on the belly and more likely to make them vomit a lot. Babies also in heart failure tend to wheeze. Not all wheezing is asthma. I always laugh when you get a 1-month-old that they say has asthma. And I'm like, if you just do an X-ray, you would see that the heart size is large, and maybe you need a cardiologist, not a nebulizer. So those are just some things to consider.
Okay, great. Great. Now, if another one is if congenital heart disease is not picked up at birth, how does it typically manifest later?
Okay. So, well, in the worst case scenario, let's take coarctation because we mentioned that. Once the ductus closes, there's no output to the system and the baby can become, they present almost like a septic infant. Same thing, like critical with cardiac failure, they can die. They can die. The two babies that died in that study from the Netherlands, one was a transposition, which I'm not sure how the baby was missed, but sometimes transpositions are born with like a VSD. So there must have been mixing of the blood to make the baby not be as cyanotic as a transposition that doesn't have a septal defect. The other one was a coarctation. So if you have no cardiac output, right, you're going to go into cardiogenic shock. So that's our worst case scenario. Let's talk about VSD, which is actually the most common. It's 29% of all congenital heart defects are a VSD, and that's the most common one that's picked up, let's say, in the sort of the newborn period. That will present itself usually 4 to 6 weeks of age, sometimes 8 weeks. Why? Why then? Why does that baby not have a murmur in the newborn period, right? We talked about the pulmonary vascular resistance. The pressure in the lungs is high, and the right ventricle and the left ventricle there's no systemic and venous system, right? The pressures are the same, and the lung pressure has come down enough to allow the lungs to open up and oxygenate, but not enough to be normal. So you won't hear a murmur. Now the baby comes in, let's say week 3 or 4 for their normal checkup with the pediatrician, right? And all of a sudden the pediatrician hears a murmur. Why? Because the pulmonary vascular resistance has now dropped to normal. And so the blood through the hole can now shunt, right? Shunting means going from one side to the other. In a ventricular septal defect, it's going to go from the left systemic side across the hole to the right side. And now it makes a sound. It makes a murmur. Okay. And so that's probably one of the most common, little bit later, average age of diagnosis is like 4 to 6 weeks because of that. Atrial septal defect is the most commonly missed congenital heart defect. Why? Because it doesn't have a murmur. Sometimes they don't remember I mentioned the right axis deviation. We've had kids that had a normal EKG, no murmur, they get an echo, maybe they came for chest pain or something else, and they have an atrial septal defect that requires surgical intervention. So that is the most common missed one. The average age for that is age 6. I would say with echo now, we pick up more of them. But since in my tenure here at St. Joe's, I've been here 10 years, we have had quite a few teenagers that were newly diagnosed that, ended up needing surgical intervention. Today we had a 9-year-old with a coarctation. Why did that kid did not have a critical coarc, right? Had a mild coarctation that worsened over time. What happens when the coarc isn't severe, they develop a collateral circulation that helps carry the blood flow. How did this kid present? I spoke to the pediatrician to let him know what was going on, and he said, only at the recent exam did she have hypertension. Now, whether or not anybody checked her pulses prior, I don't know. Today, her lower extremity pulses were not there. So that's what clued us right away with the high blood pressure, poor pulses. We did an immediate echo, and we found a coarctation with a 50-millimeter gradient. So one of the things you would do in this patient would be a chest x-ray to look for rib notching, which would be indicative of that collateral circulation. So those are some examples of later diagnoses with congenital heart disease, not necessarily life-threatening.
Okay, thank you. And before we end, I just wanted to throw in, there is a question about, does IVF have an increased risk of heart defects?
If
the woman became pregnant through IVF?
So not necessarily. We do a lot of fetal echo. I'm not exactly clear why they always refer them. I guess because of the manipulation of the fetus, you know, fertilizing the egg maybe outside the womb and then putting it into the womb and the handling. So not that we know for sure that that affects it, but we do a lot of fetal echo on those. Many of those patients are referred to us for fetal evaluation to rule out congenital heart defect. Can it also be because some of these people are older or they have other risk factors that are them to be infertile? That's also part of it. The one, just as a note to mention, there are some wonderful videos that you can, Boston Children has done quite a few. Lisa McCabe, who's a nurse, clinical nurse specialist, did some, you know, like formation of the fetal heart, fetal circulation, things like that are available. Also Khan Academy, I noticed, I didn't watch a ton of his, but they do it for the NCLEX for nursing students. But there's lots of videos. They're very short and like to the point. So those are somewhat helpful if you're trying to increase your knowledge or if you need a review for your certification exam or something might be helpful. So thank you so much for the invitation to speak. I hope it was helpful and thank you for your attention.
Well, we appreciate this, and thank you for all the information that we have. This is going to be recorded and put in our on-demand library, which we appreciate. Just a reminder to everyone who is listening, immediately after the webinar ends, as well as in follow-up email, you'll receive a link to a post-program evaluation. Your feedback is important, so please take the time to complete, and certificates of completion will be sent via the email you provide on the evaluation. Should be received in about a week. A calendar of the partnership's upcoming programs can be found at www.pmch.org on the Professional Education tab. And please join us next week for a 1.5-hour program called Preventing Maternal Deaths, Managing Hypertension and Postpartum Hemorrhage. And we also have